coming tonight. We're going to listen to Debbie tonight, Dr. Debbie Eisenhut. Many of you will recognize her face and have worked with her.
Can you use the podium, please? Thank you.
Sorry, Tim. Sorry. Thank you for coming. And many of you will recognize Debbie, Dr. Debbie Eisenhut, from her years of working here as a surgeon. And she made a decision to go work as a missionary. She worked in Pakistan for 4 years? Almost 4 years. And then she came back home for a little while and then went to Liberia. She's been there for 16 months. Oh, well, my facts are a little off. And the story we're going to hear tonight is about her time in Liberia before and during and after, and as she came home. A little housekeeping about it. I'll let her do all of her talking. She has some pictures at the back of her time and some facts there. And at the end, when we have some questions, because we are recording, there was a lot of requests from people who couldn't be here. So we want to be sure we catch your questions so people can hear the questions and the answers. We'll be running around with the mic. So if you put up your hand, I'll bring the mic over. You can ask your questions, and she's happy to take questions at the end. So thank you for being here.
How does that sound? Is that loud enough? Okay, very good. Okay, well, I'm just going to tell you a story, okay? And then in the middle of the story, I'll give you some clinical information. So there's a little bit of medical stuff here, but it's mainly just a story about how Ebola came to ELWA. Well, Liberia is in West Africa, and many of you know it was founded in 1820 by American black people. Most of whom were former slaves, and they went to look for a better life. However, some of them came as missionaries. Others went and actually built plantations and took slaves. The people who descend from those immigrants are called the Congo people, and the simmering resentment between them and the 35 native groups, the 35 tribal groups that make up the country, account for the civil war that lasted for about 14 years. And so there are a lot of repercussions of that now. SIM, my mission is called SIM, began its ministry in Liberia by building a radio station. It was the first Christian radio station in Africa. ELWA was the call sign given by the government to the radio station. So they held a contest. What could ELWA stand for? So the winning entry was Eternal Love Winning Africa. So that's what ELWA stands for. And the hospital was built in the 1960s, and this is the hospital right here. It's right on the beach, by the way. And Liberia has been through a very, very traumatic 14-year civil war that sputtered to a stop about 10 years ago. There are many repercussions of it still. The country just completely was, the infrastructure was completely destroyed. There's still in the capital city of Monrovia, most people do not have running water, most do not have electricity. And there are multiple rebel armies that ravaged the country just going back and forth. And one of them was Charles Taylor's troops. This pictures some of his troops. He taught them that if you wear white wedding dresses and women's wigs, that the bullets can't hurt you. The country considers itself a Christian nation. However, it's kind of a veneer over the traditional folk religion, and that sort of informs some of the responses that we see to the Ebola crisis and the attempts to control it. Well, ELWA Hospital has a good history with the people. It has a good reputation in the country. But it was nearly completely destroyed in the Civil War. And so SIM is trying to revitalize the hospital, trying to rebuild the standards in it. Also, Samaritan's Purse is building us a completely new hospital across the road, so we're looking forward to that, but of course the construction has been stopped on that. I came in April of 2013, and then 6 months later, Dr. John Fankhauser came, a family doctor from California, then Dr. Kent Brantley from Texas. Dr. Jerry Brown then came. He's a general surgeon, a Liberian general surgeon, very well trained. And then there are some other doctors. Dr. Patrick is a Nigerian Liberian, very, very sweet guy. And then Dr. Limfuka right now has just started his surgical residency in Gabon. So I really, when I go back, I will really miss him. So we had a very good staff. There was a lot of hope for the hospital. We were hoping to start a family practice residency program. Well, our Ebola saga began in March of 2014 when I read this headline online, 60 deaths in southern Guinea from Ebola. And I sent this email to our doctors. I said, I thought you would all be interested in this. It's a bit close for comfort. We all need to be alert to the possibility of seeing something here. And I thought, isn't that interesting? Well, 2 days later, we got word that there were 6 cases up in Foya, a city in northern Liberia right on the border with Guinea. And we were quite concerned, and we knew then we had to prepare. Our primary motivation was to protect our staff. We knew that if we got an Ebola patient in our ER or in our hospital, that our staff would probably die. So here we are. Sorry, I just put it forward here. This is Dr. Jerry Brown, our medical director, and I are just talking to our staff at Chapel, just telling them about how we're going to prepare. Well, what is Ebola? A lot of you people know a lot about Ebola already, but let me just kind of fill you in a little bit. It's one of the viral hemorrhagic fevers, kind of in the same class as yellow fever and Lassa fever, or similar anyway. The first outbreak occurred in what was then Zaire, now the DRC, in 1976, and the name Ebola comes from the river near where the first outbreak was. And all previous outbreaks have been rural and therefore more easily contained. This outbreak is unusual in that it's the first time it's ever entered a metropolitan area, and we can see the result. No one knows for sure, but it's thought that the reservoir for the virus is fruit bats in the jungle. Now, if a villager sees a sick fruit bat that's easy to catch, he might take it home and cook it and eat it. And probably when he eats it, but just doesn't wash his hands. And from butchering the animal, he can get sick. And of course, his family gets sick from taking care of him and so on. The cooked meat itself is not dangerous. Now, it's really easy to tell people not to eat bushmeat. But in the jungle, there are very few sources of protein, and people don't raise livestock. So they are hungry, so some of them continue to eat some bushmeat. It's thought that the virus can be in fruit bats and jungle deer and even in monkeys. And there's a kind of a thriving business in bushmeat there in Liberia and in much of West Africa. When I come back from the grocery store, as I turn the corner by the gas station, there's a little bushmeat market, and I've seen all kinds of things sold there. And one time I even saw what it looked like a small crocodile being sold. It's thought that the first patient in this outbreak was a 2-year-old boy who ate a mango that had been chewed on by a fruit bat. Well, Ebola is spread by contact with body fluids, and handshaking is a really big part of the Liberian culture. So that's really difficult for them, but they're trying to learn to not do that right now, at least. And simple hygiene practices such as hand washing can stop the spread of Ebola. However, if every drop of water that you use has to be purchased or carried, you're not going to wash your hands very often. It makes it very difficult for people. So hand washing is hard to do. But it's passed on by sharing body fluids, like saliva, sweat, blood, urine, any body fluid. These get on a person's hands, they get into the eyes, mouth, nose, or through broken skin, and then if the person's exposed, they can get sick between 2 and 21 days later, usually about a week. Ebola virus really is not that difficult to contain. You just identify the contacts, tell them to stay in their homes, monitor their temperature, not go out. If they're sick, don't be around anyone else. But unfortunately, early in the outbreak, the authorities in the West African countries were just not able or willing to do that. And so we're in a difficult situation now. The patient's symptoms can begin like any other viral illness, and that's what makes the triage somewhat difficult. They all have fever and weakness, but you can imagine a lot of people just with simple flu can have that. Malaria can have it. And as the disease progresses, they get more and more ill. They have, a lot of them have vomiting and diarrhea. Only about 1/3 of them have the bleeding symptoms. But once someone begins to have bleeding, hemorrhagic symptoms, or neurologic symptoms, the chance of survival is really quite low. 70 to 90% die in about 2 weeks. Now, the death rate is sometimes listed as up to 90%. That's without any care at all. Right now in Liberia, when people are getting care, the death rate's about 70%, but that's still very, very high. Triage is very challenging in West Africa. I'm going to discuss that a little bit more later. In the U.S., a patient will have a fever plus a travel history, or will have a history of a contact with someone with a travel history who's sick, okay? But almost all of them have fever. I read recently that someone said in the newspaper that 13% of Ebola patients in treatment units don't have fevers. And I don't know what they mean by that, but I know that in our unit, the people who are getting well won't have a fever. They're waiting their 3 days before they can be discharged, or the ones who are near death won't have a fever. But patients early on, one of the first symptoms is fever. So that's a good way to triage people, generally speaking. I don't think we have to fear a large, does anyone need to respond to that? Anyway, I don't think we have to fear a large outbreak of Ebola here in the U.S. First of all, passengers boarding planes in West Africa get their temperatures taken, so they're not likely to get sick on the plane. It's inevitable that some more people will step off a plane and a few days later, several days later, fall ill. But the authorities have been able to isolate the people, quarantine them, and there just hasn't been, I don't think there will be a large outbreak. One thing, at least last I heard, it's difficult to get a plane ticket out of Liberia. I know that there are only 2 carriers flying out, and I think that last I heard that the tickets are sometimes booked up 6 weeks in advance. So it would be hard for someone who knows they've been exposed to get on a plane and say, I want to go to the U.S. and get sick there. So there already is some barrier for them to come. So again, I don't think there needs to be a lot of fear about that, but we can talk about that during the question time. I'm sure you must have lots of questions. So at ELWA, once we knew that Ebola might come our way, we decided we had to get ready. And I looked online, and we found the WHO manual from 1997. And so we printed that out and started training our staff. We had 17 2-hour sessions and trained over 140 of our staff. We taught them just the basics of hygiene, how to care for patients in an Ebola unit, and how to protect oneself. And every hospital worker was expected to attend. Every participant had to put on and take off personal protective equipment. We call it PPE. Now, we didn't have any PPE, so I just used regular cloth surgical gowns, and then I used my kitchen aprons, and then you saw the bandanas there, and then just regular masks and gloves and things like that. And again, everyone participated. This group includes one of our drivers and one of our lab technicians. Even the folks in the business office participated. And I told them, money's dirty. I said, money is dirtier than toilets. And you can't be counting your money and licking your fingers. And you can't be counting the money and eating your donut. And I'm glad that we did train them, because when we started getting Ebola patients, I took care of 2 cashiers from other hospitals who died of Ebola, just because they worked in the cashier's office. And then the week I left Liberia, I went up to the cashier's office to pay for some medicine for Nancy Brightball. And I looked inside, and both the ladies in there were wearing gloves. So I was very, very pleased that they were still implementing their protection. Well, it's gratifying to see hand washing increase in the hospital. They began to own this more and more. It wasn't perfect, but they did more. When I first came in September 2012 to just look at the hospital, there was no place on the wards for anyone to wash his or her hands. And so these little hand washing stations were built in response to that. But still, the usage was not very, very much. But they began to wash their hands more, and then the glove usage went from 4 boxes a day to about 10 boxes a day. So probably there were more gloves used that were necessary, but still we were very glad to see that they were using gloves more. Well, we needed a place to treat any possible Ebola patients. Again, our motivation was to protect our staff, so we couldn't admit a patient to the hospital. We had to have a separate place for them that would be safe. And so we looked at our little hospital, And we decided the best place would be our chapel. So this is our chapel. We decided to turn that into an Ebola treatment unit. And of course, that created quite a headache for our services director, David Rightball. He's thinking there, he really doesn't have a headache. So the next weeks we're busy preparing, and here David Rightball with his services men are digging 2 deep latrine pits for liquid waste. And here he's posing inside the new isolation unit. It used to be our chapel. It had just been freshly painted. And also it didn't have lights before, so we installed these lights for the treatment unit. And I said, put in really bright light. I don't want anything worshipful. And you can see the latrine pits have been covered with little shelters, just simple shelters. There's a toilet there and a sink. There's no running water. Here's the running water. They're proudly showing off this little spigot they've made for us. And then we looked online and watched some YouTube videos and saw that in Ebola units, they dry their gloves and their boots on sticks. So I told the services guys, I said, go find the straight stick tree and make me a stick forest. And then we needed a place to triage patients, because you can't bring people in the ER, decide they have Ebola, and then send them out, and you would contaminate your whole hospital. Again, the goal was no Ebola patient in the hospital. So Samaritan's Purse built us a triage tent. And here's the completed tent, and here's the inside. It was like an oven in there, but it did work very well, and we used it throughout the entire outbreak. It's still probably being used now. Nancy Rightball is our personnel director, but she's also a trained nurse's aide, and she wanted to be involved, and so she was involved from the very outset. She trained all of our outside support personnel, the sanitation workers, and did the inventory, and she was very essential. Here she's showing another lady, Nancy Shepard, how to mix bleach. Well, we consolidated all the supplies that we had, but our cupboards were pretty bare until the first pallet of supplies came from Samaritan's Purse. And I remember making it the first list of things that we needed. And I felt so greedy because I'd asked for hundreds of this and hundreds of that. Well, it turned out to be just a drop in the bucket. But Samaritan's Purse supplied us throughout the entire outbreak very generously, very continuously. They sent pallet after pallet like this, air freight. You can imagine how expensive that was. But we could not have done it without that. So here our cupboards aren't so bare now. All of these boxes with a little hole contain lactated ringers. To take care of Ebola patients, you need lots and lots of IV fluid. They also need lots of potassium supplementation, and also to prevent, because they get really profound hypokalemia, and they also need blood transfusions. Unfortunately, in Liberia, you can't do any of that, and that's why the death rate is so much higher there than it is with patients here. Here we're putting together blood pressure cuffs, labeling garbage can. It takes a lot of stuff to run an Ebola unit. And by the way, our first little unit, we call it ELWA1, has just one room. So we took care of suspected patients right next door to confirmed Ebola patients. So all the fancy blood pressure cuffs and thermometers we had were just single use. We threw them away after every patient because we didn't dare keep them. Here, Kent Brantley is showing Ruby how to mix chlorine solution. We started out with bleach, and it takes a lot of bleach. So later on, we switched to chlorine granules, which the kind used for swimming pools. So it's a lot easier to manage those. Now, Doctors Without Borders, I'll refer to them as MSF. That's the French acronym. They normally respond to Ebola outbreaks. However, they were just really busy in Guinea and Sierra Leone, and so they were not able to come and be the first responders in Liberia. But Claudia from Italy and Anya from Germany came and toured our unit, gave us suggestions, and were very, very, very helpful. They also gave us their latest manual. Now, Anya, on the right here, told me, she said, Debbie, this manual is just a draft, so don't give it to anybody else. Well, I ended up giving it to Samaritan's Purse, and now I've sent it to all of our West Africa hospitals. Now I've sent it to all the hospitals that asked for it here in the Willamette Valley, so sorry, Anya. So one afternoon, they showed us how to put on real PPE. By now, Samaritan's Purse had sent all the real PPE, so we're showing us how to use that. So our little 5-bed unit was beginning to take shape. We refer to this now as ELWA 1, and I mention that because if you get online, you'll see reference to ELWA 2 and ELWA 3 on news reports, and those are units 2 and 3, but this is ELWA 1, and it's just five beds. You can see all the stuff we have, the garbage cans with chlorine solution, the sprayers, and all the different things we had, all ready to go. So our introduction to the care of patients with viral hemorrhagic fever began actually with a sort of a false alarm. One day Kent Brantley called me from the ER and said, Debbie, this guy here I think he might have Ebola or Lassa fever, I'm not really sure. Well, he ended up dying shortly after that. So I got 2 workers and we got dressed in PPE and we dragged the bed out to the triage tent. And then I came back and sprayed the ER where he'd been. And then when someone with Ebola or any kind of viral hemorrhagic fever dies, you can't give the body to the family. The Ministry of Health is supposed to come and pick the body up. Well, the family dug the grave and got the coffin like they were asked to do, but the whole process took about 2 days. And so here we are, we're spraying things, and we've got the body in the coffin, I'm spraying around there. And the family by this time was quite angry, as you can imagine. This is the second day, and it's hot. And so while we were doing this, the family with a crowd of supporters was outside the gate there yelling and throwing rocks. Eventually, the Ministry of Health did come and took the body away and helped the family bury it. But for us, it was kind of a sobering introduction to the care of patients with viral hemorrhagic fevers. Well, we got our first Ebola patient about 8 days later. We had trained our staff to take care of Ebola patients, but you can imagine they were quite frightened initially. We had to go around and really cajole and beg and ask people to come work in the unit. We wanted everyone to work at least once, and most did. And after we'd go in, we'd come out, I would ask them, how did you feel? And they would say, oh, I was so hot and uncomfortable. But then I would say, did you feel safe? And they would say, yeah, I did feel safe. So it really took care of some of the fear that people had. And then we got a core group of people that were willing to work in the unit full time. And it's very difficult to wear these Tyvek suits when it's hot and humid. The temperature is between 90 and 100, and so is the humidity. But what we do is we put on the Tyvek suit and then a heavy apron and then double gloves, and then you wear should wear a hood. We didn't have hoods initially. I'll explain that a little bit later. And hood and mask and goggles. And we also wear rubber boots. Here, Nancy Wrightball is using duct tape on Kent Brantley's gloves, and Elizabeth is doing the same thing. The outside support person is a very, very essential part of the team. Here, Nancy is helping Kent put on his PPE, and she's inspecting him. And that's one thing that we talk about what happened in Dallas, with the 2 nurses that got sick. I suspect that they were putting on and taking off their PPE by themselves. And this observer, what the CDC now calls the observer person, is absolutely essential. Putting on PPE and taking it off is never done alone. Now, it's okay to improvise. Initially, we didn't have hoods, and so we would zip up our suits and have this little bit of skin here exposed. So what Nancy did was she took some booties and she cut them open, and then she would tape them up on us with duct tape. And so we called them our beards. So we could be a gray beard or a white beard. So here Kent Brantley is a white beard today, but it was very effective. But then later, of course, we got proper hoods. And before Samaritan's Purse sent us our first pallet, I was experimenting. What could we do if a patient came before we had anything? So here I experimented with a garbage bag, just with the garbage bag and regular mask and regular hat, and we probably would have been fine with that. We learned to write our names on our foreheads. Here you can see Dr. Debbie, Dorothy, and Dr. Natalie. I'm training 2 Samaritan's Purse workers, and you can see we're covered head to toe. There's no skin exposed. You can't mess around with this. Unlike these ladies that are apparently, someone sent this to me and said that this is what the CDC advertised as proper PPE. But this poor lady, her head and neck is completely exposed, and look, she's wearing her own tennis shoes and her own scrubs. And that's just not, if you actually have a suspicious patient, an Ebola patient, that's not going to work. And it's one thing to put on PPE, but I'm going to explain that taking off is the most important step, because you'd imagine she's got her gloves there, and then she's going to reach up and try to get her mask off, and that's where you get into trouble. The first CDC guidelines were quite inadequate. I haven't looked to see what the new guidelines are, but I understand they're better. But you can again see completely exposed head and neck area. We always prayed before heading in. Here's Nancy leading a group, and when the burial team came, we also led them in prayer, and I've seen several pictures of the burial team in Monrovia preparing to go into homes, doing the same thing, and I said, they learned that at ELWA. But once inside, we were able to give fluids, pain medication, and other care to patients. And many were, as they got sicker and sicker, were incontinent of diarrhea, or they vomited and needed basic nursing care. They just needed lots of care. We had a protocol, actually the MSF protocol, we followed that very closely. And they all got hydration, either oral or IV hydration. As people got sicker, they wouldn't be able to drink, so we would give them IVs. And then they all got malaria treatment. Many Ebola patients have both malaria and Ebola. So just something for the ER, if a patient who you think is suspicious has a positive malaria smear, that doesn't mean they don't have Ebola also, so just remember that. They would get IV antibiotics or oral antibiotics, systemic antibiotics, and then vitamins, and then pain medication. Many of them were in a lot of pain. And so it was basically just supportive care. We really didn't have a lot of specific treatments for them. Here you can see Kent Brantley sitting at a patient's bedside, just talking to him. Now, as I mentioned, we would have suspected patients and confirmed patients in the same room in ELWA 1, because that's all we had. But we were very, very careful. We would take care of the suspect patients first, and then after every action, we'd go over to the little spigot and rinse our hands in bleach water. So you can see I've just washed my hands, and I've just wiped my gloved hands with a paper towel. And then you go to the confirmed patients, the true Ebola patients. You never go back to the suspect patient. And we never infected a patient who came in who was not, we never infected someone who didn't have Ebola when he came in. You can see Dr. Brantley sitting at a patient's bedside. This is one of our little survivors. He's showing him a Ranger Rick magazine that his children donated. They also gave him a soccer ball. So. Well, we couldn't keep records in the unit. You can imagine if you had a chart in there, you'd have to burn it. So what we would do is we would take the vital signs, and then we'd go to the door, we'd yell out and talk to our outside support person. Here Elizabeth is writing down vital signs that Kent is dictating to her. Many patients have diarrhea or vomiting, and so they have to have their runny stomach buckets emptied. And what we would do is we would just pour the chlorine solution in the bucket, let it sit for a while, then take it out and dump it in the latrine, and then we spray it with bleach or chlorine solution, and then rinse it out and wash it. And if you had a patient like that in the hospital here, what you'd want to do is just pour chlorine solution in that body fluid container, whatever it is, and then it would be safe just to pour into the toilet. You wouldn't have to dispose of it in any special place. When we finished, we'd come outside to be decontaminated, and this is the high risk zone on this side of the unit. We would have to be decontaminated one by one, and the decontamination process is more important than putting on the PPE. It's very, very important. The first step is to rinse my hands in the chlorine solution, and then I would take off the duct tape and my outer gloves. And then here Nancy Shepard is spraying me off front and back with the chlorine solution. Then I take off my apron, put it in the big garbage can full of bleach, and then I'd stand there and she'd spray me off front and back again. And you can see Nancy's right ball is teaching Nancy Shepard how to be the outside support person. You can see she's standing there with the protocol. Again, this is her job is very, very vital. And we would after a while we actually had it posted on the wall. But she would call out the step, and she trained all the people she trained. She trained them to be very bossy. You stand there and say, you spray them off, and you say, okay, take off your mask. Now wash your hands. Take off your goggles, wash your hands. Take off your hood, wash your hands. And I would come out, I would be very tired, dehydrated. My brain would be addled. So it was very helpful to have someone stand there and just give those instructions each time. That way you don't make a mistake. I just consulted with the urgent care that I'm working with, and what they're going to do is just after every step, they're just going to wipe their gloves with a disinfectant wipe, and that would be perfect. Okay, so you don't have to have a bucket of bleach there. You could use a disinfectant wipe, but after every step, have to take off your mask, wipe your hands. Take off, every step you need to wipe your hands. That way you're not reaching up here with contaminated gloves and touching your head and neck. And then I'm taking off my suit. The outside support person would have sprayed that zipper already. I'm zipping it up, taking it off, putting it in the garbage can. And then the last thing I do is wash my hands in bleach, my inner gloves in bleach, and then take the inner gloves off. And then they'll spray my glove, my boots, front and back, and then he or she will ask me to lift my foot, spray the bottom. I'll step over the line and do the same with the other foot. And then I go through the foot bath. The boots are put in the garbage can full of bleach. They sit there for 30 minutes and then they're dried here. Meanwhile, I've gone over and washed my hands in first bleach and then soap and water. So there's a very definite protocol. Coming out, we would just be drenched in sweat. In LO1, we had such a small team, we would be in there 3 or 4 hours sometimes taking care of patients before the work would get done. And so we'd come out quite dehydrated. We'd go sit down and do the charting and try to rehydrate. But still, when I would sleep, I would have muscle cramps. Well, it wasn't our intention to be the only Ebola treatment unit in the capital city of Monrovia. MSF had gone down to the main medical center, JFK, and had set up a beautiful Ebola treatment unit there for 20 to 25 patients. And they trained the staff, and then it, of course, went back to Guinea or Sierra Leone. But that unit never functioned well. They took care of some healthcare workers from Redemption Hospital. And initially, they wouldn't even go in to take care of the patients. They just put the IV fluids and the medicine inside the door and expected them to give their own medicine. And there was one young doctor, a Ugandan surgeon, who was texting his friends outside saying, "They haven't fed me for 4 days." So they did do better for a short period of time, but then towards the end, one of the patients got loose and ran out and chased all the staff away. She went and got the diesel fuel that was used to burn the garbage, and she went into the room where all the PPE was and burned all the PPE. So the Ministry of Health decided to just wash its hands of Ebola care. And they notified us. They didn't actually ask us. They just notified us and said, your unit is running well. We want to bring our staff up to you and have you guys be the Ebola providers for Monrovia. Well, we were horrified. We were trying to run a hospital at the same time as running this unit. And by the way, we doctors and nurses were also taking our regular shifts in the hospital as well as running the Ebola unit. And so we just knew that we couldn't do this. We just didn't have the personnel. But we met with Samaritan's Purse, and they said, we've been talking about this at leadership, and we want to actually provide Ebola care. We don't want to just provide the logistics and the funds. We actually want to do patient care, because they could see the need that MSF, there just weren't enough people with MSF. So they said that they agreed that they would take over the work at ELWA and FOIA when they got their system up and running. But their epidemiologist told us that our little 5-bed unit would not be big enough. They said, you're going to need a bigger unit. So we looked at the grounds of our compound and decided that the new kitchen laundry facility for the new hospital wasn't finished, but it was there, a building there. And we said, well, we could use that as an Ebola treatment unit. So Samaritan's Purse began to work on that. And then the epidemiologist said that this epidemic's going to outstrip that as well. We need a big tent hospital. So they began to construct a large tent hospital on our compound. So this little unit is now is called ELWA 2, and you'll still see that referred to on the internet as ELWA 2. And then the big unit that MSF is running now on our compound is called ELWA 3. Well, triage of Ebola patients can be challenging because the illness can mimic so many other illnesses. And here you can see Kent Brantley talking to one of our ER nurses about a patient. You can see the family standing by. And changing the behavior of our hospital staff in the ER was difficult. I mean, it's hard for anybody to change. But it used to be that patients and family could just wander in and out of the ER at will. Well, we had to stop that. We couldn't have that happen. So what we did was we roped off the ER, and then we had a security guard standing there to keep people away. Sometimes at night, I'd go up there and find him sleeping, though. So there was a lot of training that was necessary. But we would have people sit on a chair, and they would have to get their temperature taken. And only when they were afebrile with no fever could they come in the ER. If they had a fever, then a doctor or nurse had to come and triage them to see if they could come in the ER safely. But suspicious patients were treated initially in our triage tent. This patient actually didn't have Ebola, but he ended up in our treatment unit for about 4 days. By the way, when the Ebola test is not positive till day 4 of illness, so you have to keep people in the unit for 4 days, and then if it's negative on day 4, then they can be cleared. So we would have suspicious patients there for several days sometimes. But this man turned out to not have Ebola, but he was discharged well from the hospital. But triage was difficult, and one day I got word that an ambulance was coming with two people in it, 2 suspicious patients. But Dr. John Fankhauser went up to triage them. He was wearing full PPE, and he sent for me, and I came up to see what he wanted. And he said, "Debbie, these 2 ladies, they don't seem that sick. I don't know if they could have Ebola." And I said, "Did they tell you that they are the mother and daughter of the nurse at Redemption Hospital who just died?" And he said, "No." So I went back to question them, and he told me later that he asked them 3 more times, and they still denied it. And finally, on the 4th time, they admitted that yes, that was their relative. So triage, it was very difficult. So for some West African patients, not all, but for some West African patients, their belief system makes them makes them believe that if you say something out loud, that it can make it true. And so that makes it difficult in just regular medical care to talk to people to tell them their loved one might be dying, because if you say it, then you've killed them, basically. And so that can make the triage of Ebola patients challenging. If they admit that they've been in contact and they might have Ebola, then they've made it true. So that's a challenge in triage sometimes. Well, in spite of our efforts at triage, we had one Ebola patient end up inside the ER. So we decided to do some retraining. And so I'm training some of our ER nurses, and we're pretending to be lax security guards and angry family members. And here Ramel is a real sick Ebola patient. You can see that she probably has Ebola. So the second training included this song, and rather than have me sing it, you have to sing it with me. So this this goes to the tune of 10 Little Indians. So I'm going to cover my microphone, and you're going to have to help me sing. Whoops, I don't know if I do this, okay? So here we go, you guys. Got to help me now. Headache, vomiting, runny stomach, too much weakness, pain in tummy, pain in muscles, swallow hurts him, hiccups and can't breathe. He wants to vomit, he can't eat, went to a funeral, touched the body. Someone near him has just died, maybe he's a case. So now you can triage an Ebola patient if he comes to the ER, right? So where am I here? So anyway, it was difficult to care for so many young, healthy patients who died of Ebola. They were previously healthy. And some were more heartbreaking than others. And Francis is one such patient. He sold used clothes down in the market. And one day, the slipper salesman next to him was sick. So he carried him home. And he found out later that the slipper salesman had died. And he went to the house, and there were Ministry of Health people there. And he asked them, what was this all about? And they wouldn't tell him anything. Well, a week later, Francis came to us with Ebola. And he ended up dying. But initially, he was sick, and then he seemed to get a little bit better. We had high hopes that he might survive. But then he got sick again and died. And that illustrates one of the characteristics of Ebola, in that people can have what's called a pseudo-remission. They do okay, they're really sick, and then they seem to get better, kind of start eating again, feeling better for a day or two, and then they develop hemorrhagic symptoms or neurologic symptoms and go on to die. And also if they get hiccups, that's another thing that indicates that they probably will not survive. But it was difficult to see someone like Francis pass away, because he got sick just because he was a good Samaritan. Also, you can see the wall clock. You don't have your watch in there, so how are you going to take pulses and respirations? So we would carry a wall clock around and do it that way. We just wipe it off between patients. We also took blood pressures just with palpation because you can't put the stethoscope in your ears. So our physical assessment of patients was pretty basic. The death rate was pretty high. About 6 weeks into the epidemic for us, we only had about 3 survivors, and 2 of them are young boys. And this is our first survivor. He and his family were very, very grateful. And here he is again. There's Dr. Brantley, Dr. Fankhauser, me, and Dr. Jerry Brown. The week I left Liberia, he and his uncle came to my house to see me, and were very, very grateful. Here's our second survivor, little William. William's mother was a nurse's aide, and she got sick because she gave a bath to a nurse who had Ebola. And again, she was just trying to help. But now William, when his mother died, he is now an orphan. So I just feel bad for him because he didn't have, and his family, the rest of his family really didn't come to see him very much when he was sick. So I don't know what's happened to him. Well, Samaritan's Purse ended up having to stop work on Elba 3, the Big Ten hospital, because some members of the surrounding community began to protest and threaten violence. They threatened to burn it down. They were very, very, very afraid. The Liberian National Police was deployed on our compound, and then I didn't see this, but I just heard about it because I was too busy working, but the UN military came, and even the Liberian Army came once with a tank to disperse a crowd. And leadership made the rounds of government offices asking for support and security. Here you can see our Samaritan's Purse field director and Lance Plyler, the head Samaritan's Purse doctor, talking to the vice president, just explaining, you have to provide support and security for us to build this hospital. Liberia will need it. It's not an option. But there wasn't really, at that time, wasn't much response. Well, the new unit, Elwa 2, was finally ready on July 20th. And Dr. Kent Brantley and one of the staffers with Doctors Without Borders had gone down to JFK, the main medical center, and had trained their staff for the whole week before so they could come up and join us. Here you can, this is Elwa 2 now. This is the typical patient cubicle. And so July 20th was a very exciting day for us. We moved all the patients over from Elwa 1, and then the JFK patients came up and joined us. All their staff came up and joined us, and then the whole effort was turned over to Samaritan's Purse. And then Dr. Brantley became the medical director of Elwa 2. Here you can see him having his first team meeting. We were all exhausted, and many more patients were coming. The new unit was, as you can imagine, a bit chaotic, but things were going well. Here you can see the workers putting on their PPE, and here you can see the observer, the support person helping, taking her job very seriously. The decontamination folks getting ready for people to come out. And of course, they still prayed before going in, and everyone still put their names on their hoods, so that's good. But then 2 days later, Nancy Wrightwell developed a fever. And then the next day, July 23rd, Kent Brantley developed a fever. And July 26th, their blood test came back positive for Ebola. Needless to say, we were stunned, and we couldn't conceive of how they could have been infected. We felt quite confident that it wasn't while wearing PPE in the unit. Nancy had never gone into the unit, and I can talk about this freely now because it's become public. When I returned to the United States, John Fankhauser and I wrote an 11-page report and sent it to the CDC and asked them to do a formal investigation and make it public. They did do somewhat of an investigation, and that was published as the latest MMWR. It wasn't it wasn't a very well done investigation, but at least it's public information at this point. Kent is convinced that he got sick taking care of an Ebola patient, that one Ebola patient that made it into our ER. He had to go up and spray the ER after that. We also had 2 healthcare workers who got Ebola in the community, one from his sister, another one, we don't know where he got it, but they came to work sick and infected, I think they may have infected both Kent, Nancy, and then one of our nurses. Fortunately, all 3 survived. The 2 healthcare workers who came to work sick both died, unfortunately. Also, that same week, Samaritan's Purse workers up in Foya, up in the north of the country, came under attack, and Samaritan's Purse had to pull their workers out of northern Liberia. And you've probably read about there have been multiple attacks on healthcare workers in West Africa. There was one team up in Guinea that was killed, and the reasons for this are varied. There's a lot of fear. Samaritan's Purse did a survey of over 1,000 people in Liberia, in Monrovia, asking, is Ebola real? And 89% said no, Ebola is not real. Some believe that now that may be changing though. I don't know if that's changing now. But some believe that it's a plot by their government to get money from foreigners. Others believe that Ebola is spread by foreigners. And this internet meme, Ebola-chan, is one of those. It just represents represents that belief. They think that foreigners are coming and giving people Ebola. And people think that the treatment units are actually factories to harvest organs to sell in other countries for black magic. Also, there's a lot of resistance to having the patient be taken away to be taken care of in an Ebola treatment unit, because if they die, they won't get the body back. And now they're very upset because the bodies are being cremated. So there's many reasons for the fear and the anger sometimes. Well, because the security situation had deteriorated and there wasn't a lot of support at the time from the government, Samaritan's Purse leadership met with the president and told her that this problem had outstripped the resources of these two private organizations, and said, you need to appeal to the international community. And Samaritan's Purse and SIM, my mission, decided to pull all its workers out. So the response was turned over to the Ministry of Health and WHO. They had some people on the ground, and most SIM and Samaritan's Purse leadership were then evacuated. And the rest of us turned our attention to the care of Kent and Nancy. This is the outside of the Wright-Ball home, looking like an Ebola unit. Now, when we began our Ebola response, Nancy Wright-Ball, our personnel director, told us, if we get Ebola, our travel insurance will not evacuate us. However, when this happened, SIM began making phone calls, and one of our SIM missionaries, who actually works in the U.S. now, made a phone call. Had been working with a State Department official, and when this happened, he called him and said, is there anything we can do for Kent and Nancy? And he said, well, there is a plane that's outfitted for this, but it's been sitting in a hangar for 12 years, and it's only for diplomats. So he said, is there anything you can do? And he says, well, we can probably renegotiate with the company this understanding. So he did, and that company agreed to come get Kent and Nancy. So we were thrilled to hear about that. We knew that they were going to be evacuated, but we had to keep them alive until then. And I also need to mention that no tax money was used for this. Our government doesn't evacuate sick people. It's our job to get travel insurance and our missions took care of us in that regard. David Wright-Ball's faith and just strength was just amazing. Here I'm coming out of the Wright-Ball house. Carrie's going to spray me off, and here he's holding the door for me. Here his wife is in there, sick with Ebola, and he's smiling for the camera. So. Because only a few workers were available to take care of Kent and Nancy, even David Wright-Ball suited up to go in and do some patient care for his wife. And here Kathy with Samaritan's Purse is helping him get dressed. Well, David Wright-Ball, John Fankhauser, and I belong to a very select group. We've washed dishes, cooked, and done laundry in full PPE. Now, this picture was put online and on the Oregonian website, but the reporter captioned it, "Dr. Debbie fixes a snack for herself in the Wright-Ball kitchen." So I called her and said, please change that. They're going to say, no wonder those stupid missionaries got Ebola. Well, an NIH researcher who was working at the lab in Liberia came and talked to members of our team about several experimental treatments. She mentioned 3, and she came to Kent's window and then to Nancy's window. Here David is visiting Nancy through the window, but came to her window and talked to her about these experimental treatments. The decision was made to give them one of them. It's called, what it's called now, ZMAP. It's a cocktail of antibodies that had only been used in monkeys. And there was actually a course in Sierra Leone. I imagine it was positioned there in case an MSF worker got sick, but they flew it down. And here I'm holding one of the bottles there. All 3 doses were mixed there on the right wall kitchen counter, and the bottles said on them for research purposes only, not for human use. Here you can see John Fankhauser hanging one of the infusions. Well, Kent was the first to be evacuated, and we were thrilled to see him walk out of the ambulance there in Atlanta. But Nancy had to wait another 3 days for her evacuation. And then 3 days later, she was evacuated. And here we are putting her into the pickup truck, the specially modified pickup truck. The evacuations occurred in the middle of the night just because that's when the planes could leave. And then I climbed in after that and rode to the airport with her. But we were thrilled to see her take off into the night. That next night, after we had a good night's sleep, we all went out to eat. Here you can see the Samaritan's Purse team and the SIM, John Fankhauser, David Rightwell, and I. The next morning, the Samaritan's Purse team took off and chartered DC-3 and went to Burkina Faso and got on commercial airlines from there. But we were going to go with them. But by this time, there was a lot of publicity, and we found out in the middle of the night that David Rightwell and I were on a no-fly list because we were contacts with Nancy, so we stayed behind. Our mission debated what to do with us, and they decided that, initially they were going to leave us there. But then they decided, what would happen if we did get sick? And there was no one there to take care of us. Even we didn't have the PPE, all the equipment. We didn't have anything. So they decided to go ahead and spend the money to evacuate us. So here's our plane on the tarmac in Monrovia. And here we are getting ready to leave. It was John Fankhauser and me. And here I'm taking my temperature just for the camera. It was a very nice flight. I'd never done that before. And when I got back to Charlotte to mission headquarters, I told our president that when I go back to the mission field, I want to go back like that. And he said no. So there was our SIM worked a lot with the CDC and the local county health department, trying to figure out how to take care of us. And I said, just put some tents in a farmer's field. Well, our mission headquarters is on a very nice property, and actually there's an RV park there. So they parked several RVs. That's the RV I stayed on. That's the Rightwell RV, and we just stayed there. We called it Ebola Summer Camp. So we finished our quarantine there. And as soon as Nancy got out of the hospital, she came camping with us. So it was very nice. But the suffering in Liberia continues. The WHO is predicting that the number of cases will reach 1.4 million. After we left, the construction on Elwa 3 continued. This is very small now. If you get online, in fact, there's a great YouTube video about the largest Ebola treatment unit in history, and it's a flyover of Elwa 3, and it's just amazing how huge it is. But that MSF was able to free up people, and they're running that now. An MSF doctor has said that all they can provide, though, is a mattress and oral rehydration because there are so many people. So then it's just the numbers are too overwhelming to provide much care. And both Elwa 2 and Elwa 3 have had to turn away patients. There have been some times where they've just wandered the compound and the area outside the compound just looking for care. I think it's gotten a little bit better now, but I'm not really sure. Our medical director, Jerry Brown, is running Elwa 2. You can see that Elwa 2 in the background there. Excuse me. But he struggles to maintain standards and safety without a good supply of PPE and medical equipment. They are getting more survivors than before. They estimate that the survival rate is about 70%. When we first started this, we read that perhaps the virulence would drop a little bit, and so maybe that's happened, but it hasn't dropped very much. Many of you know that Rick Saker flew in just as we were leaving to help Jerry Brown open the hospital. Well, they opened it just for OB patients because there was no place in the whole capital city of Monrovia for people to have a C-section or a complicated delivery. Well, he took care of a bleeding OB patient who turned out to have Ebola, and as you know, he got Ebola and was evacuated back to the U.S. Our hospital is now open only for pre-registered OB patients. But that's one of the catastrophes of this whole problem, is that there's no place to go for a broken arm or a ruptured appendix or bad malaria. The main hospitals are just closed. The government burial teams haven't been able to keep up with the deaths, and so they've started to cremate them. Well, what can we do? And I tell people that we can't turn our backs. The situation seems impossible, but when things are impossible, that's when God does his best work. And we read in Proverbs, deliver those who are being taken away to death, and to those who are staggering to slaughter, or hold them back. If you say, see, we did not know it, does he not consider it who weighs the heart? And does he not know it who keeps your soul? And will he not render to man according to his work? And I don't feel that we can turn our backs on people who are in distress. There are things we can do. We can pray, we can give, and we can go. And if you're interested, there's a handout there with prayer requests, and there's information on giving, and you can also information. You can go with SIM to work at the hospital or help on the Elbow 2 Ebola treatment unit. You can go with Samaritan's Purse to do community health teaching, or you can go with MSF to work on the Elbow 3 Ebola treatment unit. So anyway, but that's what I have. So thank you. So I think we're going to take questions. So. I think they want to get the questions on the tape or on the.
I heard you say a 70% survival rate now with Ebola. Is that accurate? Because I thought that I had heard 70% death rate, so I was a little confused.
I was wrong. Yeah, 70% death rate. Sorry about that. Yeah, thank you. 70% death rate. With this strain of Ebola, the Zaire strain, the death rates can be up to 90%. But I think that's without any medical care at all. So it's the death rate that's 70%. Thank you for clarifying that. Thank you.
I was wondering how many years of experience they would like for people who are interested in going to any of the facilities to help in treatment and education.
0 experience. Okay. I think they really would like people to go. I think they're sort of somewhat desperate. People are sort of afraid to go at this point, but I don't think we need to be afraid to go. The CDC wants me to go back to Atlanta to be a trainer. So December 1st, I'm going to go back to take their course, and then if they like me, then they'll keep me on as a trainer. So they have, if you get on the CDC website, you can see that there's a training course you can do back in it's Anniston, Alabama, which is about 100 miles from Atlanta, and a 3-day course. And then they would train you, and then you could go. So I'd really recommend that you go take that course first. I don't think you need to be especially afraid to go take care of patients wearing full PPE. If you're doing it with an organization like MSF that knows what they're doing, this doctor in New York who got sick, I hope they're going to investigate how he got sick. But I would be surprised if it occurred while he was wearing full PPE. Ebola is sort of endemic in the community. And one thing you have to be careful is the healthcare worker that's next to you could be sick. And after we had our experience with Kent and Nancy, all of our workers have to have their temperatures taken at the beginning of shift and mid-shift. And that's why we wanted the CDC to do an investigation and make these recommendations public. So I don't know if MSF is doing that or not. Also, this is not the time to go to have a cultural experience. We stayed out of the bazaars. I went to the grocery store, the main grocery store, but not out in the community. You can't go out in people's homes. You can't go wander the streets. And I wonder if that's what this doctor did. You can't go out, and you should stay in your quarters and follow the protocol. So I think, I hope that people will still be willing to go and volunteer.
So I have a couple questions.
Mm-hmm.
We've been hearing a lot of talk about the immunity. Is the immunity sustained, or just like we have to be vaccinated for influenza and such each year, does it go away? And then is also the immunity
does it work for all the different strains of the hemorrhagic fevers?
Good question. Kent and Nancy were told that they're immune. I don't know how they know that. Okay. Now, of course, Nancy tells me that she's being followed, and I think that they will use them as guinea pigs for some years to come. I would not trust that personally. I wouldn't go take care of a patients without PPE if I were they. And I don't know if it's immunity to all 4 strains or just the Zaire strain. So I don't really know, and I don't think anyone really knows that.
And then are they looking at, so we've heard about the Dr. Brantley doing the plasma transfusions here for the nurses and whatnot that also contracted the Ebola. Are we seeing that in Africa and in the affected individuals, or there's not a means in which to do that? Or
there's several reasons. One, there's no way to even type people in the Ebola unit. And you can't send it to your regular lab. You know, there's a need for little mobile labs to be in the unit to tell people to find out what people's blood types are, and then you could get type-specific survivors to give blood. And there are enough survivors now that they might be able to do that. So that would be helpful, I think. I just read in the paper that Nancy just gave blood to this doctor in New York. I think it was that doctor in New York. Anyway, but she just gave blood to somebody. And I don't know how helpful that is. It's all experimental.
And then you mentioned the 4 days until they test positive for Ebola. So is that 4 days from the onset of a fever?
From the onset of illness. And also I should mention that people do not shed virus until they're ill. If someone's well, they're not going to be dangerous. And if they're not very sick, they're not shedding much virus. In fact, I was around Nancy the first couple of days of her illness, and I hugged her once. I'm a hand washer, so I washed my hands. I even had supper in their home during one of those nights. David did the cooking. You know, she didn't touch anything, but wasn't that sick. So if they're not that sick, they're not shedding that much virus. The more sick they are, the more virus they spread and they shed. And a dead body is the most dangerous of all because there's a tremendous amount of virus on that body.
Is that why they say then it can actually be longer than 21 days? Because if you have a low exposure to begin with, it takes longer than 21 days before, or you haven't heard?
I've read that, and I don't know where they're getting that. I don't know if that's true or not. I don't know if that's just a rumor or whether that's medically true. So.
I can't help but ask this question. So, you know, we thought we had an Ebola case and everybody was on high alert here. And then luckily we found out it was a false alarm, but I think it made everybody really think about what could happen and what would we do. And then I saw guidelines. Well, first they came from my nursing association on how to put on and take off a gown. And then it came from my other association in imaging, same kind of thing, that were set up by the CDC, which were totally inaccurate. And so, of course, I started sending out emails to my director like, wait a minute, you know, I just saw Debbie in the newspaper and she's decked out in full gear, you know, and we're not getting this. What happened with the CDC? What do you think went wrong in their...
I don't really know, but you know, I never got on the CDC website and looked at their standards, and it wasn't until after the 2 nurses got sick that someone in my mission sent those pictures to me that I showed you, and that's when my mission said, Debbie, why don't you contact them and see if they'd be willing to have you come, you know, to help train. But I think they sent some information as well. So I don't know where they got their information. But you know, it's crazy because they could have just asked MSF. MSF would have been happy to enlighten them and help them and train them. Really, I mean, this is not. They don't have to reinvent the wheel. So.
I'm wondering if in all the pictures of all the units in Africa, there's bleach and chlorine, which is not a unit available thing here. If we did have anybody that had Ebola in this general area, is I mean, you mentioned hand washing as being adequate, but when you're washing in chlorine, that's a little different than just hand washing or using the alcohol wipes. So I was wondering if you could speak to what we actually would have to do to keep ourselves clean.
Sure. The virus is actually quite fragile. Even sunlight kills it. Hand washing can kill it, but dilute chlorine solutions kill it. And everything we did was overkill. Because the stakes are so high, especially in Africa. If you get sick, there's a very good chance you'll die. So I think even the antiseptic wipe on the gloves would be adequate as long as you used it well. Almost any good disinfectant would do it. We had chlorine solutions and we had bleach. That's what we used. So I don't know if that answered your question. So.
Hi, Debbie. Thank you for your work, and thanks for coming to share your experience. Just really admire what you've done. I'm curious what your opinion is regarding quarantining health workers when they get back from serving.
Well, my opinion, I don't know what will happen, but my opinion is that if they know they've had some sort of exposure, then that's different. They should quarantine themselves in their home for 21 days. But if they have just been taking care of workers in full PPE and have not had any exposure that they know of, I think they should be given a piece of paper and a thermometer and say, take your temperature twice a day for 21 days, and if you get sick or have a fever, lock your door and call 911 or call the authorities. I think that's adequate. I hate to see people quarantined, volunteers who go to West Africa to help, to come back and be basically put in jail for 21 days. I think people are going to be, it's going to be hard to get people to volunteer for that. So if people aren't sick, they're not a danger to anybody. The doctor in New York, as soon as he got sick, he locked his door and called 911. And so he did the right thing. He wasn't out exposing people when he was sick. So I don't know, that's my opinion anyway.
So with the potential Ebola patient that we had here, it was a surgical patient. So now surgery is setting up Ebola protocol, just in case, even though the Ebola patients are not typically surgical patients. It would be the potential patients that we would deal with, and it sounds like the best site to go to would be not the CDC and go to MSF.
Well, I sent Kent I sent Court Garrison all the stuff I had, so he has it now. So you could contact him and get it. I don't know, it actually. One of the problems with Ebola patients is many of them have very severe abdominal pain, and one of the ways that healthcare workers get sick is by doing laparotomies on them. And of course, they're negative, and they find out, oh, they have Ebola, and then everyone in the operating room gets sick. So it actually is not unreasonable that a patient would come in with an acute abdomen and have a negative laparotomy. So. In fact, Jerry Brown, apparently there were 2 patients that came in since we've left, they've actually operated on because they thought that they had acute abdomens. None of them got sick, fortunately, but because they all were protected themselves. But it wouldn't be unusual for an Ebola patient to end up in the OR. So. Okay, so I don't know if that answered your question or not, but I don't know where to go for help for information other than the MSF manual about how to protect oneself.
Okay.
So that's what I think.
All right. Thank you.
Mm-hmm. Oh, actually, I've changed my mind. I should mention that American College of Surgeons is also working on protocols, so you might want to go there and see what they have. I haven't checked out what they've written, but that might be an option.
Hi, Dr. Eisenhut.
Hi.
One of the questions that we were talking about is how long do you think it stays alive, like in droplet precautions on like a surface?
When we first started this, I read that it would stay alive on a surface for 7 days. Now, I've read recently that that's not true. It has to be moist stuff, you know. So again, I don't really know that anyone really knows. But again, we did a lot of reading when we first started our preparations, and that's the first thing I read. But more recently, I've read the other thing I mentioned.
Okay, thank
So,
you.
Yeah. So any more questions? When are you going back? I don't really know. My mission has asked me to go to the CDC training, and so if that looks like something if I would be useful there, then they want me to do that for a while. So we'll see. Well, thank you very much. Thank you.